Welcome, everyone. I'm Kelly Grant, Vice President of Business Development and Admissions for Caron Treatment Centers. We're excited to have you today in the fifth of 6 webinars focused on our new state-of-the-art 100,000 square foot medical center, the Keele Center in Delray Beach, Florida. Thanks for joining us as we count down to Keele. First, some housekeeping issues. Today's program will be conducted in webinar format, meaning you can see and hear us, but we can't see and hear you. However, we would like for you to be involved. So please utilize the Q&A feature in the bottom right-hand corner of your screen to ask questions. Please know that if we do not have time to get to your question, someone from Caron will follow up with you. And please note that today's webinar does not include continuing education credits. And lastly, this webinar is being recorded and will be posted to Caron's YouTube page. Now we are going to show you a short clip of the construction of the Keele Center. I'd also like to share some of our most recent construction photos to give you an idea about the inside look of the Keele Center. Here is the outside of the building. This entrance is where most patients will enter as they admit into the Caron continuum. However, we do have private entrances for those patients that require more discretion and anonymity. Next, you are looking at the Courtney and Kevin Beebe Grand Lobby, which is on the other side of the entrance. And lastly, renderings of our fitness center, ancillary services suite, which will include acupuncture, massage, Reiki, and other amenities, as well as our Neurocognitive Services office. Today, we are talking about neurofeedback and neuropsychological services at the Keele Center in Caron, Florida. First, we have Dr. Alexakis, the Director of Psychological Services at the Keele Center and Caron, Florida. As a clinical neuropsychologist, her primary role is to assess comprehensive neuropsychological assessment and assist in diagnosis and treatment planning. Since beginning her tenure at Caron in 2015, Dr. Alexakis has instituted a full range of assessment services, including intellectual, academic, career, psychological, and neuropsychological testing. She also collaborates with her Caron colleagues to create integrative screening assessment that combines neurofeedback, brain mapping, and measures of cognitive functioning and personality. She's also consulted with various schools and organizations throughout Florida, as well as internationally in the United Kingdom and Grand Cayman. She was the first neuropsychologist to work in Grand Cayman and helped develop one of the first learning centers within a private school setting. Next, we have Allison Steiner. She began working at Caron as a neurofeedback technician in 2014, and she became the program coordinator in 2015. As one of the first employees in the program, Allison helped to build the Alpha STEM program and set up the neurofeedback laboratory. She has a master's in social work from Case Western Reserve University and is currently enrolled in a master's of public health program with a focus on health information at George Washington University. I will now hand the program over to Dr. A and Allison to describe the neuropsychological services available at the Keele Center in Caron, Florida. Thank you both.
Thank you, Kelly, and welcome everyone to our webinar and to our countdown to Keele. I'd like to begin with a brief overview of the psychological services that are available at Caron, Florida. These diagnostic services are available through the Department of Psychological Services, and they're administered by licensed psychologists with specialties in counseling psychology, clinical psychology, and clinical neuropsychology. A neuropsychologist is a doctoral level clinical psychologist with specialized training and expertise in the applied science of brain behavior relationships, or rather in understanding how the brain functions and its relationships to cognition, emotions, social functioning, personality, and behavior. Neuropsychologists are involved in the assessment, diagnosis, treatment, and neurocognitive brain training or remediation of patients throughout the lifespan. Our testing services are driven based on individual patients and treatment team concerns, and they include a full complement of objective, and by that I mean norm reference standardized measures, self-report measures, as well as performance-based or subjective projective methods of assessment. These may range from brief initial integrated screening assessments to comprehensive psychological, psychoeducational, career interest, and neuropsychological evaluations. The test findings and the recommendations are then reviewed with the patient and their treatment team to help inform and guide in the development and implementation of individualized evidence-based treatment interventions. Now, why testing in the first place? There are many reasons why an individual might be referred to the psychology department for testing. One of the most common reasons for testing is to assist in differential diagnosis, to help identify or clarify coexisting disorders, differentiate between neurocognitive disorders like dementia and psychiatric disorders like depression or anxiety. As mentioned earlier, testing is used not only as an assessment and a diagnostic tool, but more importantly, in the treatment itself, to guide and to inform the treatment planning process. For instance, would an individual base most from which evidence-based targeted interventions based on their testing? Could it be CBT, cognitive behavioral therapy, or dialectical behavioral therapy, DBT? In cases of trauma, would this patient benefit more from EMDR, eye movement desensitization reprocessing, or CPT, cognitive processing therapy? What specialty groups would be recommended? Again, based on the information gleaned from testing. What about other treatment recommendations like mindfulness, EEG neurofeedback, cranial electrical stimulation, or alpha stim as we use it here, the safe and sound protocol? How about targeted brain training exercises to improve cognitive functions like memory? So there are many reasons why we use testing to improve, again, and guide the treatment planning process. Another reason is to establish a patient's current baseline cognitive functioning. For example, it might be important to identify areas of strengths and weaknesses. Let's say a patient reports a history of dyslexia, and they're having difficulty completing some of the treatment assignments that they're given. Testing would help us identify what accommodations or what modifications, if necessary, would be needed that the treatment team can implement so as to assist that patient to make the most out of the entire treatment process. Another reason that we refer individuals for testing is to assess their treatment response, especially in medication management, to monitor their progress and their change over time, and also for a younger population who might be planning a return to an academic setting, and perhaps they have a history of specific learning disorders or ADHD, processing deficits, social communication difficulties, maybe even test anxiety. Testing can be used then to provide any necessary documentation that they would need in order to obtain accommodations so that interventions and assistance can be implemented to promote their academic success. Another reason for testing is to assist with continuing care planning after treatment. So what types of diagnostic assessments are available here at Caron? The first one, integrated screening assessments. This is a collaborative effort merging two disciplines of psychology and neurocognitive services. The integrated screening assessment is available to our patients, and it consists of a combination of brief neuropsychological and psychological screening measures that are administered along with concurrent QEEG brain mapping by the Neurocognitive Services Department. These test findings and personalized treatment recommendations from both disciplines are then correlated and merged into a summary report, which is reviewed with the patient and their treatment team. Neuropsych screening as well as QEEG brain mapping are repeatable assessments, and thus they're ideal for measuring change over time. A comprehensive neuropsychological assessment might be warranted. This helps to uncover underlying mental health or neurocognitive conditions that might be harder to identify with other types of testing. An individual may be referred for neuropsychological testing because they're experiencing, for example, short-term memory concerns. They're losing things, they're forgetting names, they're forgetting appointments. There might be increased confusion, difficulty with attention or concentration. Perhaps they're having difficulty finding words or recognizing and labeling items or objects. They may be having visual spatial issues, problems with making decisions, problems with impulse control, or changes in personality, mood, or behavior. A comprehensive neuropsychological assessment is extensive, and it includes a clinical interview, observational data, review of any previous records or treatment, in addition to administration of standardized assessment measures of such areas like intellectual functioning, memory, executive functions like reasoning, judgment, problem solving, abstract thinking, planning, organization, attention, language, visual spatial skills, motor functions, social skills, emotional and personality functioning, as well as academic achievement and cognitive processing measures. Psychological assessment is another battery that we have available when the clinical concerns are focusing primarily on identifying and clarifying the patient's current emotional, social, and personality functioning. Objective self-report measures, as well as performance-based or projective measures, are used, in addition to brief neuropsychological measures that could be administered at such a time. Psychoeducational assessments are recommended when it's clinically necessary to diagnose and document evidence of specific learning disorders, attention deficit hyperactivity disorder, or processing deficits, again, for the purposes of obtaining academic accommodations. In addition, career assessments are also available for those individuals who desire to further explore possible academic career paths or occupational areas of interest to pursue. Maybe it's to assess their school motivation and their learning styles and study strategies, perhaps identify personal working styles and work values, or evaluate their current level of occupational stress experienced. Such assessments can be helpful for young adults trying to decide what academic career paths to pursue, or even older adults who may wish to explore different avenues with respect to possible career changes or what other areas they may be interested in, perhaps after retirement, in terms of pursuing a sense of purpose. At this point, I'm going to turn it over to Allison Steiner.
Thank you so much, Dr. Alexakis. That was a wonderful summary of neuropsych services. And I will speak a little bit about neurocognitive services at Caron. One of the main tenets of care here at Caron is that recovery should involve the whole person, their family, their environment, their friends, their physical health, their employment, and their spiritual path, whatever that may look like for everyone. That also includes addressing the target organ of substance abuse and mental health, the brain. And today I'll be talking about how our programs at Caron specifically support the brain during the recovery process, and the interventions we use to ensure that recovery is not just possible, but probable. One of the services that we offer here is a baseline evaluation of brain activity, which includes a quantitative EEG, which is a measure of the electrical activity in the brain, which helps us to determine which, if any, parts of the brain are under or over functioning. The quantitative EEG is a completely non-invasive process where an electric cap with sensors is positioned on the patient's head while he or she sits comfortably. The sensors on the cap detect electrical patterns produced by the brain. We then compare our patient's brain activity to a statistical norm based on age and gender matches. While this process is not diagnostic, it does help us to identify brain patterns related to anxiety, trauma, inattention, memory issues, depression, concussions, or traumatic brain injuries. Following the QEEG assessment and neuropsychological screening, the Neurocognitive Services Department works closely with the Psychology Department to create an integrated assessment review that marries these assessment measures. By looking at the underlying electrophysiology and the brain output, both cognitively and emotionally, we create a comprehensive review of the patient's functioning that helps to inform the treatment process. The QEEG scan is the part of the process that really determines the rest of treatment from a neurofeedback perspective. It is our initial assessment and consistent marker of change throughout the neurofeedback process. We can take this measure repeatedly throughout a patient's time in treatment to identify any changes that occur. We utilize the QEEG scan to determine appropriateness of treatment for neurofeedback therapy, alpha stim, or safe and sound. We also use the EEG recording to create a protocol, which is essentially an individualized treatment plan for the brain. Neurofeedback, alpha stim, and safe and sound all work through 3 different mechanisms and will be best for different clients. Someone might be appropriate for all 3, and someone also might only be appropriate for 1 or 2. We use your brain map and a conference with your clinical team to decide which intervention will be a best fit for each person. So, diving in specifically to neurofeedback, what does an actual neurofeedback session look like? During the neurofeedback session, a patient wears an EEG cap while observing a visual and auditory stimulus, often in the form of a video game. While the patient is observing the stimulus, the EEG system is visually analyzing and monitoring their brain data in real time. The video game will provide real-time feedback based on the brain data that is gathered second by second. During the training session, the video game will stop or start based on the level of irregularity occurring in the EEG data at any given second during the training session. This is the part of training where having a good neurofeedback technician or clinician is so important, because we want someone guiding the patient to question their own internal experience during this process. We want to ask the client, what's occurring for you when the game is playing? What's going on when the game stops? What are you thinking about? How does your body feel? Are your shoulders tense? What's your breathing like? Are you present? Do you find yourself drifting off? And we want to correlate that to what's happening on the screen. It's this the patient to increase their own mind-body connection and their ability to self-regulate. Moving on to alpha stim. Alpha stim is a medical device used as a non-pharmacological treatment of anxiety, insomnia, depression, and pain management. Alpha stim can be used in a clinical setting or at home following a doctor's order. When using alpha stim to treat anxiety, insomnia, or depression, 2 ear clips are placed on the earlobes. These ear clips send a very, very small wave directly to the brain for 20 minutes. This waveform helps to amplify activity in some areas of the brain while deactivating activity in others. This process of neuromodulation helps to increase feelings of calm, well-being, and ease. And then moving on to the safe and sound protocol. We call it SSP. SSP is a powerful, evidence-based auditory vagus nerve intervention, which is designed to reduce stress and auditory sensitivity, as well as calm behavioral and psychological states, while also enhancing resilience and social connection. The SSP is a practical, bottom-up application of polyvagal theory. SSP's auditory intervention is designed to regulate the autonomic nervous system. The music is scientifically modified to stimulate and tone the middle ear muscles, which are directly related to the functioning of the vagal nerve. Middle ear muscles have been found to be underdeveloped in many individuals who experience stress or trauma and/or who have trouble regulating their behavioral state and social engagement. Thank you so much for your time. I will now hand the program back over to Kelly. Thank you again for being with us today.
Thank you, Allie and Dr. Alexakis, for that comprehensive overview of neurofeedback and neurocognitive services that we will be offering through the Keele Center as well as Caron, Florida. We're now going to shift gears and answer questions that have come in from those of you at registration, as well as people who have submitted questions using the live Q&A feature. As a reminder, you can still submit a question using the feature in the bottom right-hand corner of your screen. This first question, Allie, I'm actually going to give to you. The question is, how is success measured with the 3 different neurocognitive treatments that we have discussed?
Sure. Thank you, Kelly. So I'm going to split my answer into 2 parts. For Alvastim and SSP, our measure of success is based entirely on patient self-report. We don't have any objective measures tied to the success of that intervention. It's really just a process of checking in with the patient, marking behavioral targets, and looking to see how their subjective experience has changed over time. Neurofeedback is an entirely different story. For neurofeedback, we take an EEG on the patient every single session, and we're monitoring the changes in the brain over time. So we use that objective data-driven measure to identify, is the training working? Is the training not working? We also, when a patient comes for a neurofeedback session, provide surveys. So this is a little bit of a subjective measure. We give the patient a validated survey that says, how's your depression today? How's your anxiety today? How's your stress level today? How's your insomnia? And we map changes in those surveys over time as well, along with the changes in the brain data. So those are kind of our 2 methods.
Thank you. And Dr. Alexakis, this question I will give to you. Are neurocog treatments similar to psychotropic medications, and that you'll have better results if you do them in conjunction with traditional talk therapy?
That's a great question. So we know from research, many years of research, that the combination of psychotherapy or talk therapy and medication management together provides better prognosis than when used individually. So I would say the same occurs between neurocognitive services and medication management, that both together are better than singularly alone.
Thank you. And Allie, this next question, you touched on it a little bit, specifically with neurofeedback, but they are asking, what are the minimum number of sessions for neurofeedback, Alpha-STEM, as well as Safe and Sound protocol?
Sure. So for neurofeedback, we recommend a minimum of 10 sessions. With that being said, research shows that the more sessions you do, the more effective the service is going to be and the more deeply ingrained the changes will be. Alpha-STEM, we like to think of as a daily intervention. So the patient can really just inculcate that, ingratiate that into their day-to-day recovery toolbox, and it can be something that they use as often as they like, or as infrequently as they like also. Obviously, if they're experiencing symptoms, we want them to use it more. For Safe and Sound protocol, it is a standard structured 5 hours of listening, and after those 5 hours, the intervention is complete.
So this next question actually is a segue into that, Allie. Are the results permanent? Are the benefits permanent once you complete the initial protocol, or does it need to be continued, sort of like a use it or lose it?
Sure, that's a really good question. So we always view neurofeedback as an adjunctive service that helps to support the changes made in therapy. So what we see is that if a patient maintains the behavioral changes that they're starting to put into practice here in treatment, many of the changes that we see during the neurofeedback process remain. However, if a patient does end up regressing or relapsing, there is a high likelihood that we will also see a mirrored regression or relapse in the brain activity. But generally, if behavior continues on the upward trajectory, we'll see that the brain will remain regulated over time.
Thank you. Dr. Alexakis, this question is specific to testing. And is it appropriate for someone to be medicated for mental health conditions when completing these evaluations for fear of misdiagnosis?
Okay, another very good question. Well, we have to be able to take an individual where they are at that particular point in time. And we have to take any medication into account. Like, for example, if someone is on anti-seizure medications, there are certain anti-seizure medications that, can cloud, right, or dull cognitive functioning. But obviously, we're not going to take that away. What we will do then is report the test findings as this is the person's current functional status while they are on medication management. The same thing happens with, individuals perhaps that might be medicated for depression at the time of testing. And again, we need to take that into account, because then if the patient is still evidencing significant depression or significant emotional issues or concerns, again, we need to report that, because it may lead to, again, treatment planning in the sense of, should we revisit medication management? Should we consider other avenues, perhaps like pharmacogenomic testing? So there are many reasons why we would do both. Obviously, being off medications is best, but when it is not medically appropriate, we need to test while the patient is on medication and then take that into account.
Thank you. Allie, do you ever find that patients are resistant to receiving neurocognitive services? And if so, why is that?
Sure. Yeah, that's a good question. I would say that the vast majority of patients are pretty interested and excited in the prospect of looking at their own brain activity. It's a very different view than we normally get of ourselves, and it's a very cool service to have access to that provides a lot of insight. I will say that I do think that there is a percentage of patients who feel skeptical of the service and are hesitant to engage or curious about the efficacy and all of those kind of, understandable concerns, and when we come across something new. And when we have a patient that is, voicing these questions or concerns about neurofeedback or the imaging process, we really just provide them data, provide them resources, show them all the articles, reference back to, the beginning of these services way back in the 1920s and neurofeedback in the late 70s, and really just try and help educate the patient on the origins and the history and the research behind these services.
Thank you. Dr. Alexakis, are there instances where psychological or neuropsychological testing should not occur or should at a minimum be delayed?
Okay. It's a very complex question, so I appreciate that. I think it's important, in the best case scenario, that when we're testing, a patient is evidencing a clear sensorium. There's no evidence of an acute psychosis, for example. They're not significantly emotionally dysregulated. And if it's indicated, they've already completed detox protocols, right? So there's no significant post-acute withdrawal symptoms that might interfere with testing before we can actually initiate testing. And the reason we would like that in the best case scenario is because we want to prevent any kind of skewed or biased results and ensure that whatever test findings and recommendations we're making, that we can consider them valid and reliable representations of this patient's current neurocognitive functioning. On the other hand, there may be, again, some instances where we wouldn't delay, because what if we have a patient who comes to us, they've already completed a detox protocol, but they're still continuing to report, let's say, cloudiness, they're feeling fuzzy-headed, and they're struggling to remember things. If we can then use, for example, a screening measure to get a baseline or a snapshot, basically, of their current level of functioning, then we can remeasure. Because in the beginning, we may not be sure whether the difficulties, let's say with memory, are they due to post-acute withdrawal that is, ongoing? Could they be possibly due to a dementia process or underlying depression or anxiety? So in this case, getting a baseline measure would at least give us our first look. And then afterwards, once it's repeated, we can look to see if there are any changes or any progress. And then this will help us determine whatever next steps we would recommend.
Thank you. Allie, how long have these different neurocognitive services been in existence? And assuming the answer is for decades, why the sudden surge in popularity?
Sure. Thank you. That's a good question. So EEG has been, so the measure of brain activity has been around since the 1920s. Neurofeedback in some form has been around since the late 1970s. The type of neurofeedback that we do here at Caron has really developed in about the last 15 years. And actually, we're using the latest iteration of that. That's about 2 or 3 years old now. So what I would say is that really in the last 10 to 15 years, there's been a huge focus and a huge push in the literature to really help validate and support the use of neurofeedback as a clinical tool. And I think as more and more research has come out about the efficacy of this service and the way to effectively implement it and how we can help patients, there's been a great surge in popularity and interest in pursuing these services.
And Dr. Alexakis, how long does a comprehensive neuropsychological assessment take?
Okay. I would probably say on the average, 6 to 8 hours. But again, that will vary because as we are testing a patient, we may be pulling in additional measures. So it can vary anywhere, up 10, 12 hours, depending on which area we're assessing, where we're further delving into, documenting whatever it is we're looking. Anywhere from 6 to 10 hours on the average.
Thank you. And this next question, I'm actually going to ask that both of you answer it. Could you provide a case example of a patient's psychological profile and how you determine which of these treatment protocols is the best fit? So I will turn that over to you, whoever wants to answer first.
Okay. Allie, if you'd like, I'll pick one. I'll kind of set the stage. So let's say we had a 31-year-old individual, a young lady who came to us with a long history of anxiety as well as abuse of alcohol and other substances. Her anxiety seemed to manifest both somatically, so a lot of headaches, insomnia, heart beating very quickly, so panic type symptoms, stomach upset as well as behaviorally. So she was easily distracted. She was apprehensive about things and ruminating and thinking in a sense almost catastrophically. So Allie, you did your brain mapping with her, and I'll hand it over to you and you can discuss from there.
Sure. Thank you, Dr. A. So what the brain mapping revealed was it was a 2-part pattern. This patient had a really a pattern of excess high beta activity, which is the fastest frequency that we can measure in the EEG. It is a common pattern associated with physical hyperarousal, worry, anxiety, stress, very, very typical anxious pattern. It just tells us that the brain is ruminating all the time, always firing, lots of excess energy there. So that really speaks to the anxiety diagnosis. So we knew immediately looking at this brain map that this patient would be a great candidate for neurofeedback because neurofeedback is really effective at treating that high beta pattern. We also saw that this patient had a pattern of excess alpha activity in her EEG. So excess alpha we can see with dissociation, disengagement, some levels of maybe we'll see that pattern following post-trauma. But when we see a patient with excess alpha activity, we don't want to utilize the alpha stim Patient is already overproducing it. We don't want to stimulate it more. So that intervention was a no-go. But based on what Dr. A said, the physical hyperarousal of this patient, stomach aches, physical symptoms and manifestations of anxiety, that made her a really excellent candidate for the Safe and Sound protocol. So that's how we move forward and identified Safe and Sound and neurofeedback as a good fit for this patient clinically based on both her brain map and her clinical presentation.
Thank you for that. And I just checked, and I believe that is all of the questions that have come through. So thank you both very much for answering those. And thank you to everyone who joined us today to learn more about neuropsychological and neurocognitive services at the Keele Center in Caron, Florida. As a reminder, the Keele Center will be opening in early 2023. We'll hope you will join us for our final program in our Countdown to Keele webinar series, which is happening on January 11th. And we will wrap it up with Brad Sorty, President and CEO of Caron, as well as Dr. Phoenix Adams, Executive Director of Caron, Florida. Additionally, please watch your email for other educational opportunities through Caron, specifically our continuing educational webinars. And please reach out to your local regional resource directors for any questions you have on this or any programs at Caron. Thank you again for joining us, and enjoy the rest of your day.